Do you know every cancer affects pelvic and sexual health? Do you have clients who are dealing with incontinence post-cancer treatment? Are your clients no longer experiencing pain-free or pleasurable intercourse? In today's podcast, I talk with Michelle Lyons, a physiotherapist in Ireland, about pelvic floor therapy post-cancer. This conversation helps practitioners know what to ask about, what words to use in conversations, and where to begin treatment when working with clients who have survived cancer. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Welcome to this episode, everybody. I am super excited to reintroduce you all to Michelle Lyons. Michelle's been on the podcast before on multiple birth healing summits over the years. And thank you, Michelle, for being here. So great to have you.
It's a pleasure to be back, Lynn. Always good to chat.
Thank you. So today we're going to be talking about pelvic health after cancer. And so, Michelle, what do we need to know about pelvic health after cancer? And when we talk about cancer, are we mainly talking about cancer within the pelvic health space or cancer anywhere in the body?
Or C, all of the above.
Okay.
So yes would be the short answer to that
Okay.
question, Lynn. Because I think we would probably, be aware that pelvic cancer, whether we're talking about female, gynae cancers, or in the male prostate cancer particularly, but also testicular cancer. And I would say for both, bladder cancers and bowel cancers, we would be fairly comfortable and confident saying, yeah, of course they're going to have an effect on sexual health. We might not be specific about what that is, but yeah, that makes sense to us. But actually, just about every cancer will have a downstream effect on pelvic health. There's some really great research, particularly looking at the effects of breast cancer on sexual health. And I think if we're really going to embrace this title of being biopsychosocial practitioners, we need to understand that sexual health particularly has a bio and a psycho and a social component. So we have the direct biological effects of cancer treatments, whether that's surgery locally or radiation locally or regionally. But chemotherapy and hormonal therapies will have global effect. They will literally affect every cell in our bodies. But also, how's our body image changing? Particularly if we have an ostomy, but if we've had a mastectomy, if we've had a body altering surgery, or if we've got scarring after radiation, that's really going to affect how we see ourselves as sexual beings. And then for women particularly, so many cancer treatments will plunge women into premature menopause.
Yeah.
And so it's not your commoner garden menopause. It tends to be a pretty intense menopausal experience. So you've got all of those different aspects, but nobody is asking people about their sexual health after cancer, in my experience. And this is literally what I do clinically. I work with women predominantly who've been through hysterectomy, who've been through cancer treatment. And too many times I am hearing, you're the first person to ask me about that.
Yeah.
It's
I have both my mom and sister have dealt with breast cancer, and I've never asked them about that.
Okay, so you can play this podcast for them afterwards
Right.
and have a conversation.
Right?
That
Yeah.
could be interesting. Yeah.
Right?
Yeah.
Yeah. I don't know about you, but working on family is very challenging
Oh,
in my
it's a
world.
nightmare. It is a nightmare. It is, and a minefield as well.
Yes,
Things
yes.
things you may not ever want to know can come up in conversation. But I will say, Lynn, so we've the two extremes. We have either people aren't being asked, and that's the vast majority. But I literally had somebody last week. She had cervical cancer, and she'd been through, surgery, and she'd been through radiation. And so I was asking her, did anybody ever talk to you about dilators or vibrators? And she said, well, my oncologist mentioned it, and he said that he thought that they were a waste of time, and the best exercise was just to go ahead and have penetrative intercourse 4 or 5 times a week, and that would solve the problem.
What if you can't even get in the first place?
Well, let me just say, once I'd calmed down a
Yeah.
little bit and had drawn breath, we had, let's just say, we had a conversation about the difference between tolerating the insertion of something into your vagina that has been through so much, or maybe using, and I've moved from calling them dilators to trainers, maybe
Yes.
using vaginal trainers and talking about lube and about vaginal moisturizers plus or minus vaginal estrogen. But like, what if we actually thought about sexual pleasure rather than just sexual tolerance?
Right.
you know
Right. Yeah.
is that too much to ask? I don't think so. Oh, I was so cross.
I'm feeling that too, and it's like
Yeah,
this male-dominated medical system. It's
I
just
am over it.
happening. Yes, I am too. I am
Yeah.
too, and that's what I think, I love that you say trainers and not dilators. In the
Mm.
summit this year, Darla Carthart and I have a wonderful conversation. It was
Ooh.
so fun talking about terminology and
Yes.
and ways that we can just shift simple little words just like that to
It makes a huge difference.
yes, yeah, so please
Mm.
everybody make sure you check out that interview because it was so fun and yet so powerful. Some of the terminology, just a little shifts, and the trainers are huge, Michelle.
That's
I
a big step. And I'm going to give another shout out to Darla as well. Two things. First of all, she's the incoming president of the Academy of Pelvic Health. So all hail. But second of all, another terminology strategy that I learned from Darla at CSM just a couple of weeks ago, because we were talking about this very topic. She was talking about insertion
yeah,
versus penetration.
we talk about that too.
Yeah,
Mm,
and that's
yeah,
such an important shift, isn't it, in terms of the power dynamics and of taking control of the situation and autonomy and self-efficacy. I thought it was a really
yeah.
empowering shift in language.
Yeah, she talks in the summit interview about penetration, like in football, you penetrate the defense,
Yes,
penetrated the offense, and it's just like, yeah, you're right. It's a very aggressive kind of terminology that we need to maybe sidestep. And
I think so.
insertion
I
is more of a welcoming. I'm allowing
Yeah,
insertion to happen.
exactly, and I'm in charge of it because if
Yeah.
the conversation with Darla, we started going down a rabbit hole because we were talking about how the actual Latin root word for vagina is sheath for a sword.
Yes.
Now,
Yeah.
how's that for nociceptive imagery? you
Right.
know?
Oh,
Then somebody who's been through cancer treatment, who's maybe had surgery, radiation, chemotherapy, is on hormone blockers, it
yeah.
just it the analogy with sheath for a sword becomes a little bit too close to reality of how things might actually be feeling. And there's really no need to do that. I think good skilled pelvic rehab that looks at the whole person
Yeah.
can really be an absolute game changer. And the research, kind of talking to people, to actual humans who've been through breast cancer treatment, they want to know about sexual health and they want to know about pelvic floor dysfunction. And they would prefer, Columbage did a paper a couple of years ago, I think it was in 22, showing that people who've been through breast cancer would have preferred to know about pelvic health issues before treatment started, certainly during treatment, and definitely after treatment, and to know what resources are available. So we have to shout a little bit louder about what we can bring to the table in terms of skills to help people live well.
Yeah. Well, and I know a lot of, I guess our oncology section, people are dealing with
Mm-hmm.
breast cancer and stuff. But not all those oncology PTs are familiar with pelvic health PT. And
Exactly.
we need to partner with them to help them
Yeah,
know
I
that
think
we can
so.
assist them.
Well, I think what happens is the pelvic PTs are scared of cancer and the oncology PTs are scared of the pelvic floor.
Okay, we need to change.
And I agree. I agree 100% because it's not fair, it's not right. There's so much research And absolutely, I'm here for it. But there's so much research on regaining sexual function after prostatectomy, and we talk a lot about nerve sparing
Mhm.
prostatectomies and dealing with the erectile dysfunction that can happen afterwards, and all the medical devices that are out there. But are we actually talking about nerve sparing hysterectomies? Are we talking about what's happening to the nervous structures and the vasculature of the clitoris after bladder cancer surgery? And if not, why not? There's a gender issue at stake here too.
Michelle, I've always wondered, and I've always wondered about people who get hysterectomies and what they're doing with the uterosacral ligaments. And we know the uterosacral ligament has the inferior hypogastric plexus
Mm-hmm.
that runs through it.
Uh-huh.
And so I haven't dove deep into this, but I did have a friend who had a hysterectomy, and I'm like, talk to your
Yeah.
husband and find out what they're doing with your uterosacral ligaments.
They're not doing a thing with them, Lynn. The clitoris is just, it's such an interesting structure in terms of its innervation and its vascular supply. Um, And when we look at the damage that's done, as you said, to the uterosacral ligaments, but also a lot of women have uterine contractions as part of their orgasm. And then you're taking away the uterus. So that part is gone. There's an erogenous zone up around the neck, the anterior neck, the fornix of the cervix. If you're having a total hysterectomy, that's gone. And then you're having intense vasomotor symptoms. You're not sleeping. You've got all the side effects of chemo. um, and just literally to have conversations with these women about how to use a vibrator, pelvic floor PT to get a little bit of circulation going to these muscle groups, to make sure that we're working on restoring mobility to this area. But also, I think as well, from a sexual health perspective, absolutely. But there's more to pelvic health than just sexual health. And I think we also have to look at what's happening in terms of bladder and bowel health, because that can be such a socially limiting thing. If
Ah,
somebody is afraid that
mhm,
they're going to leak either from their bladder or their bowel after cancer treatment, how confident are they going to be to exercise? How
right.
confident are they going to be to go back to work, to socialize again? And so, that's a huge issue as well. That I think, there was a paper a couple of years ago from Patricia Malone, I think it was in 2017 or 18, but she looked at that, at the psychosocial attributes of women almost feeling guilty to ask for help with their pelvic health concerns after cancer treatment, because they almost felt this element of survivor guilt. I survived cancer, it would be greedy to ask for more.
Wow.
And if there was something to be done, surely my surgeon would tell me about it. And
Wow.
it's going, it's heartbreaking.
It
But
is.
this is why I'm so passionate that we have these conversations, because if we talk to each other, then we can, those ripples will spread,
Yeah.
and we can tell women the truth that you don't have to put up with leaking or pain or, sexual health concerns. We are here. There's research to support what we're going to do, and we can help you help yourself and give you this toolbox, whether it's, as I said, education about how your anatomy is going to work now, but the tools that are out there for anything from an O-nut to a dilator to a vibrator to just even a simple conversation about the right type of lube.
Yeah. There's so much to offer them. I know. And we
Yeah,
really we need to get and talking to those oncology docs, right?
yeah,
We need
for sure,
on
for
board,
sure.
and they all should be referring. Yeah.
Well, I mean, that for me would be the gold standard if we could have prehab, because, with respect to Taylor Swift, this is the eras that I care about, this enhanced recovery after surgery, and
Yeah.
we we see the literature emerging now, and again, hat tip to our research colleagues in colorectal oncology,
Yeah.
because they've been among the first to recognize that if you do prehab with folks going in for surgery, particularly colorectal cancer surgery, they do so much better afterwards. And we have, the evidence is there, but unfortunately we know it does take a while for evidence to
Yeah.
trickle down into practice. But I think it's a bold step forwards that evidence is there. So we need to step up and take our seat at the table
Yeah.
and show our colleagues that, it doesn't have to be adversarial. We can be passionate and collegiate, but really it would serve everybody so much better. The better shape you are going into surgery or cancer treatment in general, the
Yeah.
better your outcomes are going to be. Everyone wins.
Yeah. I just had a client reach out to me last week and she has a colostomy bag and she's going to get it reversed. And she was asking, should I come in? Should I just wait until after, the surgery? And I'm like, no, 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 no. Come in right away. Let's
Yes.
see what we're working with. Let's help you to,
Yeah.
do whatever we can then your outcomes will be much better. And she was like, oh, that makes a lot of sense. Okay, great. So, uh,
Well, I think, especially again for women of a certain age, as we move into perimenopause and beyond, our hip musculature becomes so important in terms of pelvic floor function. Because we're losing, I think it's like 2% of our striated urethral sphincter every year after the age of 35 anyway. But we know that by working those deep hip rotators, they can really be super helpful, not only in terms of continence, but also in terms of sexual function as well. Um, but who else knows that apart from us is my point. Who
yeah,
else is going to talk to these women about their hip mobility, about strengthening the abductors and the deep hip rotators, about dealing with issues like pudendal neuralgia that can arise because of cancer treatment, and to be able to kind of put these seemingly disparate pieces of the puzzle together to create this kind of bespoke whole person approach. I really think it's going to be a field that we're going to be hearing a lot more about.
yeah.
And I think not before time.
Yeah, yeah. Wow. So, so important. Holy cow. Um, I absolutely I love everything you say. You know what? When you were talking earlier about, if we're leaking, then we're not exercising. And
Hmm?
I remember one of your interviews a couple years back talking about the cardiovascular health of
Yeah,
and
yeah.
can you share that?
It's
Tell us more about that.
absolutely, absolutely. Heart disease is the biggest killer of women worldwide. Um, it's not breast cancer. It's not. It's heart disease. It will kill at least one in three of us. And we know that women's heart attacks and heart disease in general, women is not as well understood. It's definitely not as well studied, and it's not as well treated. So the biggest tool that we have is, how they say the best defense is a good offense.
Yes.
So it's about taking charge of our health. And that means exercise. It means sleep. If you are not getting good sleep, that increases your risk of heart attack as a woman by about 70%. And we know that's a hugely common side effect of cancer treatments, particularly chemo. Um, Getting that central obesity under control as well. That's super inflammatory when it comes to heart health. So those are things that we can control. And exercise is really the centerpiece that we build all this around, particularly a combination of absolutely a good walking, a good aerobic program, but actually strength training is really effective in reducing blood pressure in women. And again, hypertension is a major risk factor.
Uh,
It's great at improving metabolic function, so getting rid of that belly, visceral, inflammatory fat. And of course, it's going to be good for bone density and all those other things as well. But if you're afraid you're going to leak, how motivated are you going to be to go to a gym where there are other people? You know,
uh,
are you worried about staining? Are you worried about odor? Are you worried about somebody seeing what's happening to you? And so your circle can just become so small. And again, particularly for women who've maybe had adriamycin as part of their chemo protocol, like that's a really cardiotoxic protocol. So those
is that
women are the
spelled?
one.
Uh,
Adriamycin, it's a chemotherapy drug used for treating breast cancer.
Okay.
So
Thank
they
you.
call it the red devil, because it's a tough protocol. To be honest, it's effective, but the side effects, there's always a bill to be paid with chemotherapy in terms of side effects. And for adriamycin, it's cardiotoxicity. So these are the women that we actually need to get exercising that are going to have calcification of their blood vessels. We need to get them not only walking and doing a little bit more aerobic exercise. We need to get them strength training, and we need to get them into some flexibility training as well, because if they've had radiation, we know that can lead to progressive fibrosis and stiffening. But the flip side of that is we know that trunk stiffness and trunk flexibility is a direct reflection of arterial stiffness and flexibility. So we can work on all these things as skilled PTs who have this knowledge of women's health, of hormonal health, of oncology rehab, and kind of pulling all these things together and really working with the whole person. So it's understanding the path that they're on, what they're bringing to the table, but also being able to communicate effectively. Like, what are the barriers to you exercising? Is it because you're afraid you're going to leak? Is it because it hurts because you've got some dryness and some chafing? You've got some GSM going on down there. Let's have a conversation about vaginal moisturizers, about using lube, about the safety of vaginal estrogen for many cancer survivors, which is a tough conversation to have because the research is there, but it just hasn't trickled down yet. So we start with vaginal moisturizers, and just that ease of movement, you can just see the clouds lift, and
Mhm.
then people start getting back into their bodies again and making peace. And then once they have that relationship with themselves, of course, that's going to be beneficial in terms of their relationship with other people as well. So it just becomes this kind of full circle, because sexual health, it's on Maslow's hierarchy of needs. It's a basic need for
Yeah,
us. But if you're worried about leaking, if you're worried about, anything happening that you haven't got control over, that's a real barrier to intimacy. Um, and
pain.
so it just becomes,
Yeah,
yeah, connecting with
yeah.
the person, finding out what's important to them and what's stopping them from living well.
Right. Oh my gosh. I don't know about you, Michelle, but as I age, I am feeling so many different effects in my body because I was an athlete growing up, so my body is used to moving and exercise and all that. And over
Mm-hmm.
the years, as I have done less exercise and more work,
Yeah.
I'm noticing how much weaker I am and
Mm-hmm.
it's the effects of that. And I can't, like that alone is detrimental
Yeah.
to the body. I can't even imagine adding on dealing with cancer and
Yeah.
the drugs and all the, radiation. And
Yeah.
like that is even a huger mountain to have to climb and deal with.
Absolutely.
So much that we need to do to
It's
help.
just even to acknowledge that is an issue, first of all, I think is key, because tendons love estrogen and they get really unhappy when we take it away. So if
Yeah,
somebody is plunged into a surgical menopause with a hysterectomy, with an oophorectomy, so the ovaries are removed. So essentially they're waking up in menopause.
yeah,
They're facing into, sleeplessness. And, we all know, we've all been, we've dealt with sleepless babies over the years and
yeah,
different things. When you're not sleeping well, everything looks bleak and
oh,
grim and dark and
absolutely.
insurmountable.
I remember when I first started going into the menopausal symptoms and having 3 nights of no good
Oh,
sleep, it totally reminded me
yeah.
of those newborn days and
Yeah.
how exhausted you are, and so, yeah, sleep is huge.
Yeah, I think the exhaustion, absolutely, but just even how it changes your mental outlook
Oh, yeah,
on things, and just that the lack of optimism or hope when you're sleep deprived, it's incredible.
huge, huge.
um and so I think like that's a big part of what we need to acknowledge. So I think it's very much, yes, let's zone in on what we know about the specific pelvic healths
Mhm.
of cancer, but especially cancer treatment and menopause and aging and stress and so we're really building this composite picture of the person in front of us and what their journey is actually like. Because I see a lot of baby physios who get like really enthusiastic and they're giving the person like 12 different exercises to do, and I want you to do 10 reps 3 times a day. And you just see this person looking at them going, we both know I'm never going to do this, you know
Yeah,
so it's about understanding, I think, the person's journey, about the toll that this journey is taking on them, and then just coming up with something realistic and doable that's going to get you some quick wins, but is actually really going to move the needle for them in terms of quality of life. And that's when you start to get buy-in, and that's when you start to get enthusiasm and behavior change. That's
Yeah.
when the magic happens.
Yeah. Michelle, do you have one example of maybe the exercise that you like to go to that is more comprehensive and like your go-to exercise for someone like that versus those 12 that you might be giving them?
Breathing, breathing, literally breathing. I'm not being facetious or sarcastic, but I will literally just get them to practice some different breathing exercises. It might just be, some deep, slow abdominal breathing. It might be alternate nostril breathing to calm down their stress response. It
Yeah.
might be getting them to palpate their own coccyx externally and just feel what's happening with the pelvic floor, with the inhale, with the exhale, because we have to breathe anyway. We're doing it about 20,000 times over a 24-hour cycle. And if I can just get them every hour to tune into a couple of breaths, to get out of the little hamster wheel in their brain and just get back into their body again and to get that connection with their body again, I think that can really be helpful in restoring the relationship with the body, because a lot of cancer survivors have a lot of anger and a sense of betrayal towards their body. And
Yeah.
so they become quite dissociated from it. And the breath is just such a lovely way of, yes, calming down the nervous system, calming down the heart rate and blood pressure, but actually just getting you back into your body again. And so just by doing that, feeling your feet on the ground, softening your belly, relaxing the pelvic floor, closing your eyes, and just taking in a few deep breaths. And where do you feel that breath moving the most?
Yeah.
And honestly, it's the simplest and possibly most effective thing that I teach.
Wow. I love it. I love it. And I love the connection to like feeling the tailbone and the connection,
Mm.
connecting breath to the pelvic floor. I know in postpartum, it's very disconnected.
Oh,
Um,
yeah.
and so getting that reconnected, but that's good for all of us to know to have that
I think
connection.
so. And I think as well, I'm a nerd, so I always like to kind of tie it back into the research as well, because sometimes, what I said can sound a little bit woo and fluffy, but we actually do have a couple of really nice papers showing that external palpation of the female coccyx is a good representation of what's happening with the female pelvic floor. So it's a functional thing to do. It's an emotionally intelligent thing to do to get back into your body again. The breath
Yeah.
is such a useful tool for that. But I think, kind of correlating with what you were saying about postpartum, because we talked a little bit before we started recording about how the rib cage can be overstretched towards the
Yeah.
end of pregnancy. But if somebody's had laparoscopic hysterectomy, for example, they're in that reverse Trendelenburg, their belly is full of CO2. They actually can have some significant rib cage and diaphragmatic irritation after that. It's not entirely dissimilar to that postpartum diaphragm disconnect. So just getting that little bit of thoracic mobility and awareness back into the picture again. The breath for me is just the foundation of everything else.
Yeah. Yeah. That's where we should all start. Sounds like a
Hmm.
good plan. All right. Awesome. So, Michelle is actually going to be with us for the Birth Healing Summit this year, everybody. And
Woo.
yeah, you're going to be talking with Sarah Newman, and we're
Yes.
going to be talking about cancer during pregnancy, cancer.
Mm.
And Sarah has a very, very interesting story to share, and we're going to be diving deep into that. And the fun thing is that we're going to be doing it live this year. So, Sarah and Michelle
No
will be.
stress.
Yeah, right, I know. Let's hope there's no technological glitches that are gonna happen. When you join the Birth Healing Summit this year, you will get the Zoom link to join us for a live Zoom call, and, you'll be able to ask questions of us all and interact with us and listen to our interview live. So that will be happening Sunday. I believe it's April 14th,
Hmm.
it's a Sunday. And so I will hopefully everybody will join us and join live and feel a part of the conversation. So that's really what I was aiming for this summit. Would you want to tell people what we're going to be talking about? a little bit more?
Well, I think, I met Sarah a couple of years ago, and she's got a really interesting journey that she very bravely and compassionately shares with people about discovering that she had cancer while she was pregnant. And not only, her decision making process about treatment, but also some of the physical and the emotional fallout from that. And then, kind of we've worked together and we've had conversations about helping other women, in terms of that transition, not only through pregnancy or pregnancy loss and postpartum, but also then the effects of cancer treatment on top of that. And then fertility, how's that impacted as well? So it becomes this kind of microcosm of reproductive health that I just don't feel is talked about enough. So I'm really looking forward to this conversation. I think we're going to go deep, and I think it's going to be quite thought provoking for the folks who are there.
Awesome. I'm so excited. I can't wait. I can't wait. So, please join us for the Birth Healing Summit this year. It starts April 8th. Registration begins the end of March on the 26th. We'll also be doing another live interview on Saturday. Lori O'Neill and I will be talking about a complete assessment of the pregnant body. So, that again, we want your interaction with us there as well. And I just thought it would be fun for you to be able to attend live to some of these sessions,
Mm,
to ask questions. So that's why we're doing this. Again, we're going to keep fingers crossed that technology and everything goes smoothly. It is quite a stressor, but we're just going to hope that everything goes smoothly for that. And Michelle, I can't thank you enough for all that you do for us as physical
oh,
therapists and sharing your wisdom, the research, and all of that, and helping us put it all together in a way that we can really impact the how we're showing up in our sessions with our clients to be able to really support them. So thank you for that. And
it's my
you
pleasure, Lynn. Thanks.
yeah, and you do have courses on cancer and working with the cancer client, don't
I,
you?
I do, and probably the best way to find out about those, you can visit my website, which is Celebrate Celebrity, or just follow me on Instagram because I nerd out hard about women's health there, and I really enjoy sharing the research and having the conversations. So you can find all the information about my courses there on my Instagram bio.
Awesome. Great. We'll have the links in our show notes as well, everybody. So thank you so much, Michelle, for this conversation. As always, it's so much fun chatting with you. And I want to
My
thank
pleasure.
everybody for listening in, and we will see you all on the next episode. Take care, everybody. Bye bye.
Bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.